venture into the frontiers of healthcare data innovation with the Health Data Forum. Welcome to the Health Data Forum's YouTube channel, your gateway to thought-provoking conversations, cutting-edge insights, and groundbreaking advancements in healthcare data. Join us as we explore the transformative power of data to revolutionize healthcare delivery, patient care, and societal well-being. Embark on a journey of discovery. Delve into healthcare data through our informative videos, featuring leading experts, thought leaders, and innovators. Discover how our global movement, Data First, AI Later, is building a strong foundation for ethical and impactful healthcare solutions. Experience the collaborative spirit. Be a part of our vibrant community of health data enthusiasts, where ideas converge, partnerships flourish, and innovation takes center stage. Participate in discussions, share your perspectives, and join us in shaping the future of data-driven healthcare. Stay informed about the latest developments in healthcare data through our comprehensive video library. Catch up on insightful interviews, thought-provoking presentations, and engaging discussions about the role of data as the backbone of healthcare transformation. Join us in shaping the future of healthcare. Let's harness the power of data to transform healthcare for the better. Subscribe to our channel today and become part of the Health Data Forum's mission and our Data First, AI Later initiative to make healthcare data work for everyone.
So, greetings and welcome everybody. It's really a pleasure to be here again with all of you, and today with a special guest speaker for our interview. Our guest today is Professor Michael West CBE, a powerhouse in the field of work and organizational psychology. Holding professorship at multiple universities and visiting fellow at the King's Fund, Michael's expertise is backed by extensive research and real-world impact. He's not just an academic, he's actively involved in shaping healthcare, leadership, and improvement across England, Northern Ireland, and Wales. Thank you so much for being here with us today, Michael.
Well, thank you, Paolo, for the very generous introduction. It's a pleasure to be with you all.
It's really great to be here, Michael. And as we were just discussing the preparation of this interview, I was fascinated to know about some big data projects you're being involved. But just before that, let me just remind our viewers about the main reason I invited Michael West for this conversation. We know since last couple of months or even less, the news from NHS England, which is an emblematic organization for many of us outside Britain, that was dismantled. And obviously that's the curiosity for this conversation, to understand a little bit what's going on with NHS England. And obviously other NHSs are still fully functional, like NHS Wales is not affected by what the restructuring of what's happening in England. But Michael, please, are you able to explain the main reason for this huge transformation in England?
Well, the NHS in England, like health services in many countries, is under huge financial pressure, and there are great concerns about long waiting lists for patients waiting to receive treatment, increasing demands, aging population, pressure on staff, and health services has become a political priority, with satisfaction of people in England with the NHS at the lowest level. since we've been recording satisfaction with health services. So politicians are under pressure to do something. And of course, one of the politically attractive things to do is to say, we'll cut the number of administrators and civil servants. And so NHS England is a relatively large centralized body with thousands of staff. And the view is that there can be really important cost savings as a result of deciding to shut NHS England down. It's a national coordinating and monitoring and directing body. So it's politically popular. Of course, politicians and senior leaders find it easier to change structures than they do to change cultures. And so the consequences of this change are unknown. Some of them, of course, are known. That for the people affected, the thousands of staff affected, it's a very challenging, difficult time. They've been going through multiple organizational changes for some years. So it's been a very anxious, perilous time for them, and many of them will lose their jobs, not just at national, but at regional level too. What will be the consequences? Well, one of the consequences might be very good. If the dead hand of a centralized bureaucracy that is responsible to some extent for creating a very target-driven hierarchical culture, if that is removed or weakened, then it means that at regional and local level, staff may be more able to develop and implement new and improved ways of doing things in response to the context they face. But that cultural change is not going to happen by itself as a kind of spin-off from changing structures. I think one of the fundamental changes that needs to occur within the NHS in England, and indeed in the other UK countries, is a move away from centralized, target-driven command and control cultures. We did a review a few years ago, about 8 years ago now, of the international research on the kinds of cultures that predict high quality, continually improving and compassionate care, and target-driven hierarchical cultures are about the worst. What's I think also important to reflect on is that in the National Health Service, we have, if not then one of the most motivated, skilled, and certainly it's the largest workforce in the whole of industry. Why would we manage them through command and control? So the decision to close down NHS England, if it helps in the process of moving away from a hierarchical, target-driven culture in that sector to a more devolved, regional, team-based and integrated approach to working together to care for the health and well-being of local people, then that will be a great thing. But it's not going to happen by itself. Culture change has to be driven, particularly by leaders. And that means leaders who become much more compassionate and collective in their approaches.
Mm-hmm. Absolutely, and obviously, as you know, and I'm sure our viewers know, Michael West is a leading author in compassionate leadership. I've been in my little scale spreading the word of the work of Michael in all events that I am invited to be a speaker. It was the case in Cape Verde last year. Michael, can you expand a little bit on compassionate leadership for the viewers who are perhaps not familiar with that style of leadership you have invented? I would say created, in a sense. Conceptualize. It will be the rest.
Well, thank you, Paolo. I think the starting point is that compassion is core to what it is to be human. We are hardwired to be compassionate to others in pain or distress. And it's the core value of those who work in health services. We see a virtually universal commitment amongst healthcare staff to delivering compassionate, high quality care. What does it mean, this concept? Paul Gilbert, a guru of compassion, defines it as a sensitivity to suffering in self and others with a commitment to prevent or alleviate it. And we know from hundreds, thousands of randomized controlled trials that compassion is the most powerful intervention there is in healthcare. It's characterized by 4 behaviors of attending, understanding, empathizing, and helping. So being present with the other, seeking to understand the causes of their distress or pain, empathizing with them, and then having the intention to help them. And, one of the kind of fundamental questions in thinking about how we change culture is how we can create cultures in our healthcare organizations, given the fundamental importance and power of compassion in healthcare. How do we create cultures where staff will be even more compassionate to those they provide care for, even more compassionate to each other, and even more self-compassionate, because those 3 things go together? And the answer is that, what the last 100 years of research on organizational culture tells us is, of course, every interaction every one of us has every day is an opportunity to shape the culture through our behavior, through how warm, kind, irritable, cynical, compassionate we are. But the role of leaders is the most powerful, because what leaders pay attention to and focus on and talk about and what they model in their behavior tells us what it is that they value, and therefore what we should value. So if we're to create more compassionate healthcare cultures, then leaders must embody compassion in their leadership. And that means leaders who are present with those they lead and listen to them deeply, leaders who seek to understand the challenges that those they lead face, and leaders who empathize with those they lead, who feel what it's like to be a nurse on your 3rd 13-hour night shift in a row, where you haven't had time to take your rest break, where you feel bad because you didn't spend sufficient time with that elderly patient in distress, and where you're really now exhausted at the end of your shift and you have to drive home. And leaders who help those they lead, who have the intention to help those they lead. And that means, in the context of leadership, helping those we lead to do their jobs more effectively by helping to remove the obstacles that get in the way, and by helping to ensure that they have the resources they need to do their jobs effectively, the right numbers of staff, the right equipment that works, the right training. And, this is not a new model of leadership. As you'll know, Paolo, we've known for 60 years that these 4 behaviors are fundamental to effective leadership. The most important skill of a leader is listening to those we lead, and the most important task is helping those we lead to do their jobs more effectively. And I do want to make the important point that this is not some soft cushions, scented candles to approach to leadership, because compassion is about leaning towards pain and difficulty, and conflicts, not leaning away from it. It's not just necessarily about just being nice to people. It's about engaging with the difficult issues of leadership that we have to engage with to ensure that we can deliver for the people in our countries and communities that we serve.
Absolutely. I think that you have made an explanation so vivid of what it takes to be a compassionate leader. But the question is, are the people in charge, people that are going to be taking decisions in a structures as big as the NHS England, are they prepared and trained for that kind of skills they need to have, Michael? And what's the challenge for an organization to prepare their workforce, their leadership force in that kind of skills?
Well, I think it's a real challenge in the NHS in England. It's such a huge sector with 1.4 million people. But Wales has been showing the way. Wales made a commitment 5 years ago to develop compassionate leadership over the course of 10 years amongst all leaders in health and social care in Wales, and with the support of Welsh Government. And they've invested a huge amount of time and energy and commitment and finances into creating the conditions where compassionate cultures can be developed. So, for example, we've created a compassionate leadership training course for the NHS in Wales, which is actually being shared with colleagues in England and Scotland and Northern Ireland and Denmark and the Republic of Ireland and beyond. That program is being rolled out across health and social care in Wales. But also what they're doing in Wales is addressing the wider cultural and system issues. So it's not just about compassionate leadership, it's also about compassionate team working and compassionate policies and procedures. For example, in an Iron Bevan NHS board in South Wales, one of the issues they identified was the staff harm that results from employee investigations when something goes wrong or somebody's misbehaved. And they recognized that staff involved in those investigations were still exhibiting post-traumatic stress symptoms at least 14 months after the investigations had ended. And most of those investigations had ended without there being some, formal disciplining or firing of people. And so they've shifted the whole way they manage employee investigations to a point much earlier where they're dealt with more informally as a more compassionate approach. So they're leaning into the difficulty of investigations, but dealing with them in a more compassionate way. And their workforce recruitment and retention is being informed by the value of compassion. So they're taking a whole sector approach to developing compassionate leadership. Every NHS organisation in Wales, the boards, have signed a compassionate leadership pledge to develop these kinds of cultures. And, we talked earlier about the relative ease of changing strategy as opposed to changing culture. What was it? Drucker said, culture eats strategy for breakfast. And in Wales, what they're doing is grappling with the difficult issue of changing culture by ensuring that compassion as a value, as a behavior, is integrated into the DNA of the organization by ensuring it's informing all structures, policies, processes, values, and the training of staff. And this is not just in Wales. The Republic of Ireland, as part of its new Schlonge Care program, devolving responsibility to lead to regions, is developing compassionate leadership and team working in the senior leadership teams of all of those, all 6 regions in the Republic of Ireland. I'm working with a compassion hospital in Denmark, Esbjerg Hospital, which is seeking to train all its leaders and staff in compassionate leadership. And there are many more examples. So this is becoming, I think, a really important movement in healthcare. And Wales, as in many things in society in Wales, is leading the way and sharing resources.
Absolutely. And it's a coincidence because as we were just talking and in preparation for this conversation, Michael was not aware that we are hosting this year's Health Data Global Hybrid Summit will be in Wales. And this is a coincidence because not only Wales is a well-known reference in terms of the secondary use of health data that is done in that nation, but now we are learning, dear viewers, that it's also an exemplary health region in what concerns the adoption of compassionate leadership, and has deployed a nationwide program for training staff who is actually having leadership responsibilities to acquire these important skills that make a huge difference overall. Michael, my question to you is, I understand, and obviously that the movement is spreading, Congratulations also on the program you are starting in Denmark. I know you are involved in those programs from inception. But I have two questions for you. The first question will be, how easy is to convince a health region or a nation, like for instance, it could be my own country, Portugal, to embark on a compassionate leadership program nationwide? Are there any metrics that cost justified investment? Can you expand a little bit on that, and then I'll ask a second question.
So thank you for the question. I had the privilege of leading the design of a new national annual staff survey in England back in 2003. We administered that survey as part of our work in the university over the subsequent 8 years. But it's run now for 21 years, an annual staff survey in healthcare with over 650,000 people from the NHS in England completing the survey every year. It's the biggest, longest running annual staff survey in any sector anywhere in the world.
Amazing.
And we've been able to analyze the data over those 21 years, policymakers, academics, and so on. And just to give you a summary of some of the key findings, what won't perhaps be a surprise to all of you listening is that the element of the staff survey that most strongly predicts, or if you call it, like you can call it a lead predictor, the strongest predictor of the performance of hospitals, community health organizations, mental health organizations, is the level of staff engagement. But what may be a surprise is to learn that the element of staff engagement which is most powerful is the level of staff involvement in decision making. So staff engagement predicts care quality, patient satisfaction, financial performance, staff retention, even avoidable patient mortality. It predicts error rates, infection rates, etc. But we're also able to explore in the data what determines levels of staff engagement. And the number one factor is compassionate leadership. So the more leaders model the 4 behaviors I talked about earlier in a hospital or a healthcare trust, the better is the performance of that organization subsequently in terms of care quality, financial performance, patient satisfaction, staff well-being, etc. All of the things that are so central to the performance of our healthcare organizations. Other factors that determine staff engagement are things like working in an appreciative environment, the quality of team working. We also know that, with organizations going through such huge change, we're able to monitor over time, for example, where healthcare organizations merge or where there's major change going on. Of course, what you generally see is that leads to declines in levels of staff engagement and also increases in staff stress. But what we see is that when leaders increase their compassionate leadership during those times of merger or change, the effects are hugely mitigated. What also emerges from the data is the importance of cultures of inclusion and equity. So we know that the key predictor of patient satisfaction is staff reports of work overload. That makes sense. So the more that staff report high levels of workload, the lower is patient satisfaction. But the second most important predictor of patient satisfaction is staff reports of cultures of equity and inclusion, where everybody feels valued and respected and supported. And we know the mechanism by which that affects staff patient satisfaction. Where there are cultures of equity and inclusion, patients are treated with greater compassion and civility. And that also has an impact on care quality and financial performance. Burnout and workload and work overload are, of course, hugely negative predictors of outcomes. So the higher the levels of burnout in health services and the higher levels of staff stress that they report, The worse is care quality, patient satisfaction, staff retention, of course. And so addressing issues of burnout and staff stress is hugely important. In the NHS in England, 30% of staff report being burned out at work often or all of the time. And that's a hugely worrying statistic, because we know that those levels of burnout, we use, by the way, the Copenhagen Burnout Inventory and the staff survey, a standardized, validated measure of burnout. When staff report those levels of burnout, that's associated with staff illness, cardiovascular disease, addictions, alcoholism, cancers, diabetes, depression. So the irony is, in England, we've got, and the other UK countries, and in most European countries, our healthcare workforce is the biggest workforce in the country, charged with the responsibility of promoting health and well-being of the population. But in the process, if we're damaging the health and well-being of a huge proportion of the largest workforce in the country, it's clear that something's very wrong in the way we're leading and managing these organizations. And it's why developing compassionate leadership and compassionate cultures is so important. And the final point I would make is that this is also about compassionate team working. What emerges from this huge data set, and we're able, because we've got 21 years of data worth of data, we're able to do the most sophisticated longitudinal statistical analysis. What emerges is that quality of team working is hugely important to outcomes. The more people in an NHS organization who work in real teams, the better is care quality, much lower levels of staff stress, patient satisfaction is higher, staff turnover is lower, there are fewer errors, there's less violence against staff, much less, much more innovation, and dramatically lower levels of avoidable patient mortality. What do I mean by real teams? Well, we ask in the staff survey, and by the way, we're now using very, very similar survey across Wales. It's in its second year, and we're beginning to get wonderful data from the data set in Wales. In the staff survey, we ask staff, do you work in a team? And over 90% of NHS staff say, yes, I work in a team. And then we ask two criteria questions for real team working. Does your team have clear shared goals? And do you meet regularly to review your performance and how it can be improved? The very basics of team working. And then the figure drops to 40%. So only about 40% of healthcare staff are working in real teams. And yet the benefits in terms of the outcomes we seek are huge. So this is an easy win, just really focusing as leaders on improving team working. Now, to go back to your original question, Paolo, forgive me. When we have a data set like this, it is really convincing. But what I've discovered is, you can present the evidence once, and you may think, well, I've told the leaders what they need to know now. They can go off and recognize that they need to focus on staff engagement, involvement of staff in decision-making, reducing burnout, increasing team working. It doesn't work that way. You have to present and present and present and present and present and build a coalition of people with a shared commitment to achieving the kind of culture change we need to achieve. And to have the courage to be persistent in presenting the evidence and the arguments. But because we have such fantastic data, it's possible to do that effectively. And I think that strategy of having a clear vision of what we need to achieve and the evidence to back it up, and groups of people with a shared commitment to achieving the change who persist in presenting the data is a really powerful and effective way of convincing senior leaders to change.
Mm-hmm. Oh, it's amazing, because you are already sharing the recipe for success, right? So
Yeah.
there's a strategic vision and long-term vision of what you want to achieve with your workforce. There's the evidence you need to have to make sure that you are doing the right things. at any given time, and then obviously the implementation teams that will have to roll out the program.
Yeah.
This is
And developing, just to add, Paolo, and working together with people in health service to develop the tools that will deliver that. And we've been doing a lot over the last 10 years on developing those tools and sharing them freely and widely so that those tools are available to achieve this.
Absolutely. But Michael, this is perhaps my last question as the time goes by, and obviously we have to end this interview in a few minutes. But just before you go, the last question perhaps will be, and then maybe a final reflection. So if I'm in the position now of being an executive director of a large national health service organization, I would think about, oh my God, but rolling out a program like this nationwide, isn't this too complex? Shouldn't we be starting with a small scale pilot? What is it that you can give as a piece of advice to a national health service leader who is eager to implement this change?
Mm. I mean, my feeling is we need to do these things top down and bottom up at the same time. So there's something very valuable about working with a single organization. I described Esbjerg Hospital in Denmark. It's doing brilliantly in transforming its culture. But also, I think what's important, we've discovered, is that culture change only really works well when the senior leaders of an organization or a system commit to making the change, and not just by ticking a box, but personally get involved in leading the changes. So over the last 2 years, I've met with every board of every NHS organization in Wales to talk with them about the evidence and to, if you like, encourage their commitment to working together to achieve the change over the whole country. So I think it's creating collectives both at the most senior level and at local level so that it becomes a social movement rather than one individual trying to bring about change. If one individual alone, however senior, it's very difficult for them to really make a substantial difference. What does Rebecca Solnit, the amazing American philosopher and feminist, says, hope comes from collective action. It comes from us working together to achieve change, not from some starry-eyed optimism.
Absolutely, absolutely. I love that quote. So, Michael, thank you so much for sharing your time here with us and our viewers. I'm sure that they will be as amazed as I am with the discoveries and with the information and the wisdom that was shared here with us. A final reflection, Michael, as we look forward to data-driven health systems and to the immense power of the secondary use of health data in terms of giving people better health outcomes and to politicians better frameworks for their public policies. How do you see that the future of the National Health Service in England, the future form of NHS England will take?
So I believe passionately in evidence-based practice in healthcare. When I'm treated, I want to be treated using an evidence base, but we should also lead and manage with using the evidence base. And we have the most amazing evidence base, and we should rely on that. But there's another really important message for me is that we're human beings, and that, as I said, the definition of compassion is a sensitivity to suffering in self and others. And I think to create a more compassionate world, we all have to take responsibility for being more compassionate. That begins with ourselves, is learning how to be self-compassionate, how to attend to myself, understand the challenges I face, care for myself, and take intelligent action to help myself, not out of some narcissistic self-indulgence, but as a basis for my ability to be available and committed to helping others in pain. So compassion begins with self-compassion in order that we can be more compassionate in our interactions and spread this way of interconnecting in a compassionate way in a world at a time when we desperately need that.
Thank you. Thank you so much, Michael, for this conversation and for your final reflections and final words. It was a pleasure to have you here with us.
Thank you. It's a pleasure to be with you, Paolo. Thank you very much.
It's always a pleasure. And dear viewers, thank you so much for watching and for staying with us in this series. And hopefully we'll see you, if not in presence, remotely, in our upcoming event in Wales, the Health Data Global Hybrid Summit that will take place from September the 24th to the 26th. See you all there. Thank you so much, Michael. Goodbye for now.
Everybody's looking for a healthcare system they can trust. In the age of AI, transparency and ethical data practices are revolutionizing healthcare. By ensuring that data is handled with care, we build trust among patients, healthcare professionals, and stakeholders. Why does this matter? Ethical AI ensures that every decision made is aligned with human values, providing accountability and eliminating bias. This means better outcomes for everyone involved. But it's not just about technology, it's about trust. When patients know their data is safe and used ethically, they feel more confident and engaged in their healthcare journey. Let's embrace transparency and ethical data practices, because a trusted healthcare system is a better healthcare system. Transforming healthcare, one ethical step at a time.